Okay, Miss Weeks, it looks like it's just you and I today.
I just messaged the some people in the class to see if they're gonna join.
Okay. I'll wait a couple of minutes.
Okay.
Okay, well, this is recorded anyway, if anybody wants to see it. We are on module 4 now, and today I wanted to just run through 4B to make sure everybody's up on it. As you can see, there's been a lot of readings, and the most recent reading was actually a pretty good one because it went through pretty much a neurological examination. Pretty much how it's done in the clinical setting, but a lot of it took place in the patient's home. This section is called Neuropsychology of Complex Issues. And it is indeed complex if you really get into it. For this course, I just want to make sure that everybody has the principles and understands what's happening and what's going on in the brain there. But it won't be necessary to get into the minute details of every little thing that's happening. Oliver Sacks was a neurologist who was also an author, which is a unique combination. And I think that's why Dr. Adams chose this particular classic for us to use in the class. This particular one was written in 1985, I think. And it has a lot of information on the subject of agnosia. Agnosia is one of those more complex disorders of the brain. Basically, it means not knowing. So person's cognition is intact and their outer senses are working well, but there is a problem in the occipital lobe where vision is processed. So basically what happens is they can see things, but they don't know what they are anymore. An example is a person may think that parking meters or other things on the street are actually little kids. The interesting thing about this particular story is that it was done with a patient who himself was highly educated and he was in the field of music. But the good thing is that he was able to give a lot of feedback to the neurologist. And that's, again, how learning seems to take place, is through these case studies. And the title was just something that everyone could relate to, because during the first visit with the neurologist, when he was asked to get his hat, he, of course, couldn't remember what a hat was, and he associated it with his wife, and he grabbed her by the head. And this really confused the neurologist because he had never seen anything like this before. And that prompted him to follow up with this particular patient and follow him into his own home environment. And what he learned over time is that the weird behaviors that people had noticed with this particular person were not weird to him at all. And he had learned to adapt over time to his agnosia. And it was like he had to take an exam or fill out a puzzle every time he needed to identify something and go through whatever motions he had come up with to compensate. The senses can bind together and come up with a functional situation. Example was a rose. When he was asked to identify a rose, he had no idea what it was by looking at it. But once he was allowed to smell it, he could associate the smell, and he eventually realized what it was. So the take home here is really that there's a problem in processing sensory input in the occipital lobe and a certain part of the brain. mainly the Fusiform Gyrus, which there are two on each side of the brain, and that connects the occipital lobe with the parietal lobe, which of course is somatosensory function, the parietal lobe. So as I said, there won't be extreme detail on agnosia that you need to know, but you do need to have an understanding of what's going on there. I highly recommend that you read through this part right here, the man who mistook his wife for a hat. It's not too long, but it has a lot of detail of what's really useful here. And let's see if I can, okay, basically starts right here, and it's a few pages long, but it is a little entertaining if you like reading. The thing about neurology is it sometimes is difficult to understand, but once you finally get it, you've got it, and it stays with you then. So agnosia, that's really the big lesson for today. I'm hoping everyone has this PowerPoint. It was with this link, but it did not come up. So you had to go to your PowerPoint reader to get to it. And this just gives an overview of agnosia. It's a general deficit with knowing and not having the ability to recognize and identify objects or persons. It can be visual or can be with hearing. And as I mentioned before, it's associated with damage in the occipital and parietal lobes. So individuals with this condition, they can point and describe an object, but they have no idea what the name of it is, but they can work their way to figuring it out if there is some other sense that can pick up on it. But if it's visual agnosia, then they can't identify things by just seeing it. And this was the example I'd given about the rose, where the patient was not able to identify what a rose was until he smelt it. But from his visual input, he could not come up with rose. Another item was a glove. And even though he could describe the glove, he could not say the word glove because he did not know what a glove was, because the processing had broke down in that particular part of his brain. Even if a hand was shown to him, he still could not put two and two together and figure out that it was a glove. Prosopagnosia is inability to recognize faces. And if you do read the reading, you realize that when the doctor was in the house, there were a lot of pictures around, and he asked the patient to identify who those people were. And even though they were his family and associates, he could not name them, did not know who they were. And he even was shown a picture of himself, and he didn't know who he was. But given enough time, he would be able to figure it out. He would have to work around the deficit of not having that visual cortex connected with the other part of the brain. The other thing about faces, even if he saw unfamiliar faces, they would all seem the same. And he couldn't distinguish one face from another unless he had some cueing. And that would be something like a cartoon, or if he had associated it with some music. Since he was a music teacher, he could pretty much put everything into a song, and he would remember it there if he could sing it. Clinically today, it is known to be that this Fusiform Gyrus is associated with Asperger's and with autism, and believed to be a part of their difficulty interacting socially. They are just not able to process information the same route that other people do. However, interestingly, they may be gifted in some other area because of the compensatory mechanism, and because so much energy has gone into focusing on another sense, such as a person who is blind, their hearing may become acute to the point that they hear things that you and I are not able to really hear. It's just blended in the background noise, but they have to depend on this for survival. So their hearing and other senses become much more acute. And this was just an example of the facial recognition here. If we look at these three photos, we see that they are clearly different people.
Excuse me.
Mm-hmm.
I've been having my hand raised for like 5 minutes. But it says on the screen that it says error while processing or retrieving the document.
Okay.
That's the screen that we see.
Okay, that's on your screen. How about anybody else having that problem? Hmm. Okay. Okay, what exactly do you see on your screen? Just that message?
Yes, I see the whole Canvas screen, but the PowerPoints wasn't pulled up. It just said error while processing.
Okay, yeah, I had that problem too. And did you click the blue right here?
Right where?
Oh, did you see my pointer here?
No.
Okay. Well, I guess you don't.
Okay. Yes, I can see the screen now.
Okay, right here, did you click this? I know on mine it pulled up the PowerPoint once I did.
Oh, I was just going based off your screen, but on your screen, that's how it showed up for me because I'm using my phone right now.
Okay.
Yeah.
Okay, so you can't see what I'm pointing to here.
I can now.
Okay. All right, well, what I was saying was that these are three clearly different people here, but a person with visual agnosia or facial blindness, they could not distinguish one from the other, and they all would appear the same. So this particular guy in the story, he had a lot of music students, and he would constantly have to be reminded who they were because he couldn't pick up on their face. Everybody was the same to him. And again, these conditions are extremely rare. It's not something you see every day, but it's something that needs to be understood that can happen. And it just explains another function of the brain and when something goes wrong there. But I think the take home here is that senses bind together, and therefore if a person loses one sense, the other senses are able to kick in. And even though they won't be totally normal, they'll find a way to compensate or to survive. Other deficits with the agnosia was a person is able to abstract fine, but concrete interpretations are very difficult. And that was pretty much what I was mentioning when I was talking about integrating something into a song or a cartoon that is bigger than life. And by doing that, the person is able to again compensate. Some people are able to use movement as a way of helping them organize what they're seeing. And down here, this was where I mentioned the cartoon. This in the green is the particular part of the brain that is damaged in this condition. It's this long ridge. It's one on both sides. And it's just important to know what part of the brain is affected there. This just mentions sensation and perception. Sensation, of course, is turning the external stimuli and transforming it into a neuronal signal so that it can be processed in the brain. And perception is really what that information means to the recipient or the person. People may have different perceptions of things, even though they're looking at the same thing. It can be different for different individuals. Now, the retina is probably one of the more complex parts of the body, and it's beyond the scope of what we're doing here to really go into the function of every individual cell here, but it is important to appreciate how complex it is and what overlap there is, since there are the optic nerve, there are ganglion cells, bipolar cells, rods and cones, and all of that goes into vision. And to really understand vision, it probably would take a whole course. So we're not trying to do that. I just would like for you to understand how complex it is, and that this is just the eye, and that's half of vision. So from the retina, the signals have to be transferred to the thalamus and the genticulate nucleus, which is in the thalamus, and then it's divided up and sent to the occipital cortex and back to the parietal lobe of the brain. And it is not a simple process, but just try and understand the basic function of it. I would not ask anybody to really try to learn that. That's basically just something that shows how complex vision can be. The brain making inferences. This is a Necker cube. And the interesting thing about it is it's totally drawn in 2 dimensions on a flat sheet of paper. But when we look at it, it appears to be in 3 dimensions. And that is an example of the brain processing that and making it appear to be in 3 dimensions when we know that it's actually drawn in 2 dimensions. But that is a simple example of how the brain processes visual input. And this is just mentioning the neurological process that's occurring with the thalamus and geniculate nucleus. That's also pretty detailed neurology there. And this, of course, is not a neurology course, but we do need to understand the general function there. There is a dorsal pathway and a ventral pathway that runs through the fusiform gyrus to the parietal lobes and temporal lobes. And they also are known as the what and where pathways. So they send information about what to the brain to be further processed, and they send information to where, about where to be processed. And this is just a view of an illustration of the dorsal path. And once again, this is an important fact. Senses bind together. So you are taking in visual information and olfactory information and auditory information all at the same time. And it's sent to the certain region in the cortex, and it helps us make sense out of what we are experiencing. And this could easily explain why you get a lot of stories from, say, UFOs, where some people believe in them and some people do not believe in them. But the thing is there is some input from something, and it's interpreted different ways by different people. And one of those people is probably right. And maybe sometimes it could be a real UFO, but we know that, what is it, Occam's razor, that things that are more likely to happen are likely to be the real answer, more so than something that is very odd or very rare happening. But that's all associated with our brains and how we interpret the world. There's a dorsal stream problem known as motion blindness. And patients with this cannot perceive motion in the visual field, but have no problem seeing stationary objects. Again, this is very rare stuff that you may never see again, but it's a part of the basic science here. Another condition is optic ataxia and left-sided neglect. And that's when you diagnose this by asking a patient to draw a clock, a house, and a flower. And basically they will just draw half of it because they are totally oblivious to one half of their reality. And as you can see, this is where the patient only drew half of the clock, house, and the flower. All right. Ramachandran, phantom limb. Again, the important thing here is the parietal lobe, the somatosensory strip, which is at the anterior part. There is something known as the homunculus, which is a map of which parts of the body have the most neurons there. And the parts taking up the most space, of course, are our hands and our mouth, and then our genitals, and everything else is pretty much secondary there. But our experience of the world is basically motivated by those parts, our hand and our mouth and our genital area. This paper goes into details about a story of a man who had his arm amputated and he still had feeling there. He was able to feel pain and other sensations, even though that limb was no longer there. Now, pain presents a unique problem because pain is difficult to treat even when there is a limb there. So no one really has a remedy for treating phantom pain. And to the patient, that pain is just as real as if it were really happening. So it could be a miserable existence if the pain were to continue. But my recommendation here is just read the highlight areas. It's not that long. It'll take you maybe 10 or 15 minutes to go through it. And again, what we're shooting for is not detail, but we're shooting for understanding. That's one thing about the brain. If you go into detail, it's like a rabbit hole. You just keep going further and further and more detail until you're splitting hairs at some point, and nobody's going to understand what you're talking about anyway. So as my favorite radio host says, you need to put it where the goats can get it, where an ordinary person can understand what's happening. And that's what we're really shooting for here in this class, is just understanding. And everything is highlighted there that you need to read.
I'm sorry, you said we were supposed to read what?
What was that? It's it's in the module. Is Ramachandran phantom limb. There's just a paper there in the PowerPoint. It's the next one after the one I did before. So I don't think you can miss it. But if you have trouble finding it, just let me know. And most of this other PowerPoint stuff is a lot of review and FYI. But again, make sure you understand the five senses and what proprioception is, and that's your body's position in space. And it's mostly processed in the parietal lobe. Vestibular system is the inner ear, and it has an importance in balance. And if the bed is spinning, that is an abnormality in the vestibular system. Again, this continues to come up. Senses are binded together.
I'm sorry, can you repeat that? You said the five senses. Review the five senses.
Yeah, vision, hearing, taste, smell, touch. Those are no problem. But I don't know if you've heard of proprioception or not, but that's something that's important in a neurological exam to test the parietal lobes. You ask the patient to close their eyes, and then you put their arm or leg in a certain position. And if their parietal lobes are damaged, then they will have no idea where they are, and they will become disoriented. And the vestibular system is the inner ear. And it's associated mainly with a sense of balance. Again, senses bind together. What happens if you lose a sense? Answer's pretty simple. Other senses compensate for it. And even in a blind individual that's blind in their eyes, their occipital cortex is working fine. And if they read Braille, for example, it can be detected that their occipital cortex works just like anybody else, but they're just not getting that visual input from the eyes there. But that helps the other senses to compensate for them over time. If you saw the Ray Charles movie, it was a good example of that, how his hearing became super keen once he was blinded as a child. And he could get around just as good as you and I, even though he can't see anything visually, but he has other sensations that make up for that. What happens if you lose a limb? Pretty much the same thing. The nerves regenerate, and sometimes based on that homunculus that I was speaking of, they can regenerate in a weird place. And there is a slide that's going to illustrate that in just a minute. But neuroplasticity comes into play, and that means that neurons can grow back an axon, but it's not always predictable where they might attach to what next neuron. So you could have a neuron from your arm that attaches to neuron that goes to the face, and you could have feelings from your limb on the side of your face or other parts of your body, depending on where the neuron decides or ends up attaching. And this is an illustration of the homunculus. And as you can see, this is not normal proportions for a human being, but this is how your brain sees the world. It sees your hands as being the biggest part on your body, and your sense of taste is the second most sensitive part of the brain. And as you can see, he has oversized lips and oversized tongue. And of course, they had to include the genital region down here, which is very important in human beings and other animals for that matter. This is not a very good drawing here, but there is one coming up that's a little better. Yeah, this one can really give you a good idea of the somatosensory strip of the parietal lobe. The foot is represented in this part of the brain, hip and leg, trunk, neck, head, shoulder, arm. And of course, the hand has its own little gyri here. These are the fingers, and this is the face. And because the face area is so close to the hand and extremity area, you can understand logically why if your arm was cut off, that it might grow back with facial axons and neurons just because of the proximity of the regions. The mouth, of course, is at the latter end. And again, this is something you want to learn the basics of, just know that the foot's here, the arms here, the hands here, and the face is more on the lateral part of the brain. And that's describing the cortical neurons. And this was the illustration I was mentioning, that if the arm is amputated, the finger information is still intact in the brain. And when the regeneration of the nerves occur, somehow they could get crossed up and end up in another part of the body, such as the face. But once again, this is mainly for illustrative purposes because these conditions are extremely rare. They're so rare that I've never seen it, but this is a part of the basic science that it's important to have an understanding of. This is another device that has been used to treat amputees who have a phantom limb. And I'm not exactly sure how it works, but I know there's a mirror in here that mirrors the intact side or intact limb. And the patient goes through a type of therapy to where they learn that this side is not there anymore. And I'm not really familiar with the therapy, but apparently it works, or it wouldn't be in here. And I think this last set of PowerPoint is mainly a repetition of what I just went through. So it may not be a lot new to learn here. Again, it brings up the senses plus proprioception and the vestibular system. Senses bind together, that keeps coming up. What happens if you lose a sense? Compensation. That's the basic answer there. If you lose a limb, you do have some neurogenesis, and you can have phantom pain in the brain still. The brain doesn't know that you lost that limb and it thinks it's still there. And again, this is the homunculus. And you definitely want to know which are the more sensitive parts of your body and which are mapped out more in the brain and represented more in the brain, mainly because of reasons of evolution. These are the parts of the body that have been most important for survival. Okay, says my screen sharing is paused. And again, it's the same map. And this just illustrates in a little more detail about what happens when a limb is amputated. So it's probably something you want to be familiar with. Again, no great detail. And these are just MRI scans of where the lesion is in the brain, which doesn't really have a lot of meaning for this particular course, but it's important to know that it can be diagnosed this way and that the abnormality is physical in nature and it can be identified. Okay. Okay, are you guys seeing anything on the screen? It says my screen was sharing was paused. But if you want to use what I've talked about today, it's all in the module. And I would recommend just going through it like you normally do. And that's going to cover most of 4B. Next week, I'll talk about 4C. And you can bring any questions you have about 4B next week. But is there anything I can clear up right now?
Yes, so far you want us to just review module 4B, and then in next class you said that we'll discuss module 4C.
That is correct. And again, I think the best way to study is just to keep going over it until it sinks in. And once it's there, it's there. Again, we're not going for minute details, but we're going for a general understanding here. And I will do a review before that last quiz there. So you will be sure to know what you do need to know and not any extra stuff. But I highly recommend the reading of the Mistaking the Hat for His Wife, as it actually has a lot of good information in there neurologically. If there's nothing else, I'm gonna plan to see you next week and just look over 4B. And if you have any questions, just email me and I'll do my best to answer them. Okay.
No, I was just gonna say you have a great rest of your day.
Okay, y'all have a good week.
You too.
Thank you.
Thank you.